Great. Well, again, I'm glad you're all here for the late session. They accommodated a change. I was in Washington over the weekend working with the National Coalition for the Homeless, where I serve as the board chair in the with some meetings with HUD and the Interagency Council on Homelessness, and so got delayed in getting back here. So I'm glad to be able to spend some time with you. What I was going to present on is the coalition's vision and implementation in terms of integrated health care and housing. For years, we have believed that housing is health care, and that without housing, health care is very difficult to achieve. And somewhat counterproductive. And while many efforts of providing street medicine are extremely important, our goal is to help people move into housing and to stay in housing, and in that process improve one's health. And there are a lot of benefits to the community in terms of doing that. So I'm going to run through some slides to tell a little bit about the history and the work of the coalition and some of the developments that we're working on now. But overall, over the last 28 years, the coalition has focused on providing that integrated healthcare, housing, and supportive services, primarily for homeless families and individuals, with a strong focus on families with multiple problems and on chronically homeless individuals. We have done a lot of housing development because of the need within our community for that housing. Come on in, folks. Hi. So we had just finished actually introducing ourselves, so I'm going to put you all on the spot and let you do that. So Diana, maybe you could start by saying who you are and where you're from.
I'm Shirley Chavez. I'm in the SIG, and I volunteer for the food bank. I volunteer that we have at the center. Volunteer for anything and everything I think is possible. Every time is valuable, and so
So if you're folks outside of Denver, Quig Newton is a housing development in North Denver, where our joint effort with Denver Health on the La Casa Quig Newton Health Center, funded through the Primary Care and Public Housing Project, is located. So welcome, folks. So we're just talking about the overall role of the coalition in terms of providing integrated health services and support, providing housing development, a more recent focus on employment, and on advocacy to address the issues that the folks that we serve. Our focus around healthcare has historically been centered at our Stout Street Clinic, which was the clinic initially funded in 1995 by the Robert Wood Johnson Foundation. It provides primary health care, medical care, mental health services, substance treatment services, all through primarily through staff, psychiatrists, docs, mid-level practitioners, nurses, medical assistants, LCSWs, and the full range of primary and behavioral health providers. We have a pharmacy that's on site that provides both mental health and the medical pharmaceuticals. We have a pediatric clinic meeting the needs of homeless children. We have an eye clinic that's primarily volunteer run, a dental clinic, and we have a strong case management, morphing and merging into more care management and patient navigation as a way of addressing the needs of folks who are homeless. Last year, we served just under 12,000 unduplicated patients through our system with 1,000 visits. So through the Stout Street Clinic and our satellite clinics, a fairly robust operation. The La Casa Quig Newton Clinic is a health care and public housing development. This was actually, the clinic opened back in 1993 in what was a converted 4-bedroom DHA, Denver Housing Authority unit, where we were able to essentially provide basic physician services, case management services, outreach, and medical services. Diana, were you involved back at the beginning? And she's been with us ever since. So it was fortuitous that at the time, and this was the first round that the primary care public housing grants were available. And again, with Denver Health, the coalition and Denver Housing Authority, we put together a collaboration to receive the funding to open that initial clinic. And we operated for a couple of years at that in that small, on a very grassroots level. And Denver Health decided to close one of its health centers, the La Casa Health Center, which was about 15 blocks south of this site, and decided to build a new center on land just adjacent to the Quig Newton housing development. And at the same time, DHA received a Hope 6 grant, so provided a lot of opportunity to change the dynamics of that community, to do some organizing, to bring some new resources into the community. So what began as that small 4-unit building now is a full-scale health center, which is now known as the La Casa Quig Newton Health Center, that is primarily run by Denver Health, which is the largest hospital provider in downtown, and operates a network of community health centers throughout Denver, including now the one at Quig Newton. And so we've incorporated and divvied up our roles that rather than duplicating services, we basically have ceded the primary care role within that health center to Denver Health, and we have essentially enhanced our outreach and mental health services in coordination with them, since Denver Health does not have a very strong mental health presence within the community. And so that partnership allows our mental health clinic within the new health center to operate and to basically see patients, and then our outreach is provided for both the mental health services as well as those primary care services. So it's been a great collaboration over the years, and Denver Housing Authority continues to provide support. You can see there's Diana there, and So a number of community affairs just in terms of doing that community awareness and organizing. In addition to the work at Quig, we keep going backwards. We do operate a health outreach program, a mobile clinic that goes throughout the community to provide health services. Last year, seeing a little over 2,000 patients and reaching people who can't get down to our main clinic downtown. But as you can see from the line outside of the clinic, one of the things that we've seen that over the years as healthcare for the homeless has matured, as the needs of the homeless has grown here in the Metro Denver area, our point-in-time count shows that on any given night there's over 11,000 people who experience homelessness. Fortunately, they're not all on the streets or in the shelters. Many are doubled up or in very precarious situations during the course of the year. As many as 20,000 individuals will experience homelessness for at least a night. In our facility that initially was very large for the population and our ability to provide services, we soon outgrew it. And so as part of our strategic planning, as part of our efforts to address and anticipate the changes through the Affordable Care Act, Obamacare, and the expansion of health services or Medicaid eligibility for primarily single individuals who up to now have not been primarily eligible for Medicaid, we prioritize the expansion of our health services to meet the unmet need and the integration of services, the integration of primary care, medical services with behavioral health, mental health services, and substance treatment services, because we saw such a prevalence of those needs within the individual population as well as within a lot of the family population. And it's a little bit different than in many family-oriented public housing developments. Many of the children have had expanded Medicaid for a long period of time. Last year, only about 17% of those patients that we served through our health clinics were insured at all, mostly through Medicaid. Through a state expansion this past year, with the efforts of folks like Meg and others within our organization, we were able to enroll over 1,000 new single individuals into a state expansion. So our percentage has gone up a little over 20% now. But beginning next year, we expect that as many as 75% of those that we serve will become insured, which will then increase our ability to get reimbursed for those services. But we can only meet that unmet need if we have the facility to do it. So again, over the years, you can see it before and after. We have renovated that building many times over to try to make it more inviting, to be able to advance the medical technology and the ability to provide care have been sufficient. So we decided that we needed to do more. So the first thing we did was to build a new housing development out in West Denver. This is our development called West End Flats, our Renaissance West End Flats. This is a site of the Shuffle Inn, which is an old bikers bar that had been vacant for about 5 years. When we bought the site, we had a groundbreaking that included the demolition of the building. That was exciting to see the sign come down. And this is what stands in its place today. It's 101 apartments, supportive housing for homeless families and individuals. Half of the units are targeted to chronically homeless families and individuals. The other half are meeting the affordable housing needs of low-income families who would otherwise not be, and individuals who would otherwise not be able to rent quality housing in the community. So that housing is integrated. You can't tell when you go down from floor to floor or unit to unit whether it's a formerly homeless person or someone who is just in an affordable housing unit. 25 of the units are 2-bedroom units and the balance are 1-bedroom units. So you have that mixture of families and individuals. When we started building the building, this was along West Colfax. This is one of the busiest thoroughfares. We didn't know what we would do with the lower level. Initially, we were trying to attract a retail tenant that would be able to make use of that and provide some services to the neighborhood. But we were fortunate to get a grant from the Health Resource Services Administration, HRSA, to a new access point for a new healthcare for the homeless clinic within that area. And so the West End Health Center then was born and now operates within that space. The housing itself was built to green community standards. This is the roof that incorporates solar panels. You can see the Rocky Mountains in the background. Those who are visiting, who see the rain and the clouds, this is really what lurks behind it. Hopefully you'll see the sun tomorrow. This is one of the inside of the units. We provide very high quality housing so that the tenants treat it well because they respect it. We respect them in the way that we build and develop it, and they respect it in the way that they treat the property and their neighbors. Within the health center itself, we've been able to develop that integrated housing model, beginning with primary care or medical care, but integrating those behavioral health services. Because again, as we're seeing more and more, particularly for homeless families and individuals, that there's a large percentage of folks who have some level of behavioral health or mental health or addiction issues that they're struggling with. It may be a child in a family, or it may be the adult that is struggling with that. And that we often see that in a primary care setting, in a regular health clinic, somebody may come in because they have a chest cold, they have the flu, they have a sore shoulder, and the doc will come in and they'll treat them for that, and then they'll leave, and their other issues have never been discussed. And so what we have found that the integrated approach of dealing with both physical and mental health issues at the same time has been very helpful. You can see within, we built 11 exam rooms and treatment rooms within the new health center, so it gives us the capacity not just to serve the residents of that building, but also the residents of that surrounding community. That includes some domestic violence shelters, emergency motel units, as well as other shelters for families and women in particular. We organize the staff in a staff pod so that when they're not seeing patients, they don't have individual offices. They basically are in what we call a clinical pod. And so they're able to interact with each other and talk about patients and share information or consult. So if you have a medical assistant that's wondering what's happening maybe as to why someone's acting in a particular way, they might get some advice on that. Or you might have a doc who will be able to consult with a psychiatrist who can talk a little bit about interactions with medications. And so this approach is something that we're finding to be very useful in terms of ensuring that communication, development of an integrated care team can lead to better health outcomes and better results for the patients. This is just a diagram. This as the design coming off of Colfax, a main entry area. We have a reception area that's designed to be warm and accommodating. Actually, since these pictures were taken, we had an art gallery donate. Do you know how many paintings there were? I just walked through there last week and saw it for the first time. There must be about 35 paintings of different objects and landscapes and designs. It just makes it a very, very inviting environment. So part of it is to be welcoming to the community. We have, again, exam rooms and treatment rooms that are very typical of what you'd see when you go into a regular health clinic. but they also can be set up, and they are set up to be counseling rooms. And so if we have a psychiatrist, rather than providing a counseling session with somebody on an exam table, they'll do it around the conference table or around the desk. So that this is that area that we showed where the staff pod is, so that they can communicate. We have a treatment room that allows people to have minor treatment, minor procedures done. Anything that requires emergency room stabilization, we'll call the ambulance, but otherwise we'll deal with them there. We have a group room where they can do AA counseling groups or other types of group training around diabetes management or hypertension treatment. And so it provides really a great resource for this neighborhood, and certainly for the patients or the clients within the building. So the integrated model that we've built into this, that we're going to be replicating on a much larger scale, is this integrated care model that begins with screening. So every new patient who comes in, again, whether they're coming in because of a physical ailment or because they're coming in because of a mental health need, like depression, everyone gets assessed for both those primary care and behavioral health issues. Not very typical within the broader community. In fact, we tried to find some measures as a baseline in terms of what practice in terms of medical providers asking questions about one's depression or their, how they're feeling or their mental health status, and very little information exists, but it's safe to say that the baseline is probably very close to zero, because unless it's designed as part of the routine of the clinic, it's not likely to occur. So every patient is screened for both primary care and behavioral health issues. They have the same day access to meet a mental health clinician if they need it. So we have an LCSW that's part of the clinical team, and a part-time psychiatrist that's assigned to the clinical team as well. And I think as the clinic grows, we'll probably be adding more and more psych doc time, or at least mid-level nurse practitioner, psychiatric nurse practitioner time, so that they can help with diagnosis as well as with prescribing the medication for folks who are depressed, who have other mental health issues. All of the patient care is coordinated by the primary care physician for preventive health services, chronic disease management, acute medical care, as well as dealing with behavioral health. The psychiatrist can ensure that they get EKGs or lab results right away and reviewed by the primary care physician for any issues, rather than the typical scenario where the psychiatrist will get the test done, have to send it out for analysis, and then get the results after the patient has already left. So being able to do that without delay, immediate interaction with the individual. And for those of you who work with, the homeless population or other vulnerable populations, know that you can ask them to come back tomorrow, but they may not be in a position to remember to come back, or they may have other needs that they have to address. So dealing with as many of those issues when you have them in front of you is critical for good outcomes. And then the providers and the support staff work as a team together to deliver the best medical and mental health care that they can. So they work in that team approach, which I think is critical. So that model that we're continuing to explore and develop was not enough to take the load off of the Stout Street Clinic downtown. And so we had built a building here. The Stout Street Clinic that I showed in that initial slide is located right where that's pointed. And right next to it, in the parking lot behind it, 10 years ago, we built the Renaissance Off-Broadway Lofts, an 83-unit apartment building that, again, provides about half of the units for chronically homeless individuals and the other half for affordable housing for folks in the community. As you can see, right at the edge of downtown, if you go to Stout Street, which is like 3 blocks this way, and then go 5 blocks to the north, this is where what you will find. So we bought the parking lots and these vacant and abandoned buildings across the street, and basically designed. This is the rendering of what will be built there. Essentially, 2 levels of a health center, and then 3 levels of housing that will be up above it, 78 apartments, 1 and 2 bedroom apartments that will meet, again, the needs of chronically homeless families and individuals. In this time, with a more focused way of targeting that housing to folks who can benefit by that close proximity to the health and the behavioral health services that will be available in the new clinic. This is what the building looks like if you look at from an aerial view. Again, it takes up most of the block. This was actually where the first Stout Street Clinic was. My office, when I moved in there 27 years ago, was right there. That building is now used as a drop-in center by Urban Peak homeless program, serving homeless youth in downtown Denver. So we're working closely with them in terms of the implementation. This is the existing Stout Street Clinic, and this is the off-Broadway Lofts that I mentioned before. So you can see when we're done, we're going to have a fairly large presence within this community, and are continuing to work with the neighborhood to address the needs of folks who continue to remain on the streets. This is actually a construction picture. We have of the site. It's under construction right now. 2 months ago, and this is what it looked like 2 hours ago. You can see progress is being made. We have a webcam on the clinic, and so we have 24-hour coverage. At any point, we can pull it up on and see what's happening. I was at a meeting in Washington on Saturday, and mentioned that to someone, and they said, well, yeah, well, who's going to be working on Saturday? So I pulled it up, and we had a union crew that was out there. They were pouring. So it's great to see that happening. Some of the features that we're looking at, again, is trying to create an inviting environment that will create a space where folks can get off of the street even when they're waiting for the clinic to open. You saw in that early picture the line that forms every morning in front of the clinic. Not something that we like to see, and so we've created a courtyard so that if the clinic is closed and someone doesn't have somewhere else to be, they can have a bench in a shaded and more private area that they can wait. This is where that courtyard comes off of, and you can see it enters into then a clinic that will be twice the size of the existing clinic. We'll have a larger dental clinic that will be added to the facility. We'll have an on-site pharmacy. It'll have a larger vision clinic to deal with the needs of folks, both to get their eye exams. We deal with a lot of folks with diabetes, and unless you are getting constant eye exams, at risk of ocular vision problems, and they can get eyeglasses as well. Many homeless folks have not been able to see for years, and providing vision to them is one of the easiest things we can do, but one of the things that's often overlooked. We have a patient education area then where we can do training and have opportunities for groups. And then the housing will come in off of a separate entrance with the property management and case management offices that are there on that level. So this is what that entry level will look like, probably twice the size of the existing clinic area that tends to be very crowded and very uninviting. And so we hope to create, again, what we call a trauma-informed environment that's inviting to folks, welcoming to them, and provides them access to the services they need. On the second floor, you can see the courtyard is still there. Folks will go to the second level both by stair and by elevator. But what we were doing are creating essentially 4 suites that will be individual care teams, very similar to what I described at the West End Health Center. So they'll be interdisciplinary, there'll be doctors and nurses, there'll be nurse practitioners and physician assistants, LCSWs, psychiatrists, psychiatric nurse practitioners, medical assistants, and patient navigators. And we're working on developing consumer training for patient navigators so that those who've experienced homelessness, those who understand the issues that folks are dealing with can work to provide those services, the follow-up services. And we found that the patient navigation and the peer mentoring and combining those is an effective approach of meeting those needs. We'll likely specialize some areas. We'll have a mental health and addictions presence in each of the clinical suites, but we may over time find that the one suite may have more of a focus on chronically homeless individuals with more serious mental illness that needs to be managed on a more routine basis, and we may find that others may be focused more toward women and families and children. And so that's something that over time we will evolve by talking with our consumers, talking with our providers, and ensuring that we're providing the best services that we can. The exam rooms will be very similar to what we showed at West End, and that they'll be flexible enough to be converted from a treatment room to an exam room with an exam table, to a counseling room with a mental health or a substance addiction counselor who can work on that. So that flexibility, we think, is very important to allow us to change with the changing needs and to be more responsive to the needs of our consumers. So this is what the entrance to the residential portion, what we're calling the Stout Street Lofts, the 3 levels of housing up above, be very similar to the type of housing at West End and some of the other developments that we've done. That will be a combination of 1 and 2 bedroom apartments that will provide stable housing for homeless families and individuals. I mentioned Urban Peak, the homeless youth agency that's located next door. We developed a memorandum of understanding where we've agreed to provide 5 units of housing specifically for them, for folks that they are involved with and are providing case management services to. And then we're already providing mental health and primary care services within the Urban Peak environment, and we're hoping to draw them into the new clinic environment as well. So that's the project that we're currently working on. This is a project we completed 2 years ago that was not focused primarily on health. It's focused on getting folks off the street and providing then the integration of healthcare as part of that environment. This is the Renaissance Uptown Lofts, and 98 apartments. Half of them are project-based Section 8, and the other half provide affordable housing for other folks who could not otherwise afford quality housing in the community. It's one of the first new developments within that area, just 5 blocks east of the Capitol. And this is where our Pizza Fusion restaurant is that we opened 2 years ago this month that provides job training, transitional employment for homeless individuals, and provides a natural, healthy pizza product using an environmentally friendly footprint. So the approach, I think, has been very helpful. This is the Pizza Fusion delivery vehicle, which is a smart car. So again, saving on gas and reducing the carbon footprint. And this is the interior of the Pizza Fusion. Their motto of the restaurant is serving the earth, or saving the earth one pizza at a time, which works well with the coalition's vision of ending homelessness one person at a time. So in addition to those those physical properties, and we're in the process of building or developing another 100-unit development at 40th in Colorado in Park Hill, be 2 blocks from the light rail station going out to the airport. We have another development that's actually between downtown and Quig Newton, the 100-unit Renaissance Riverfront Loft. So providing, again, housing and then support services to folks who are living in that housing is one of the core ingredients of what we do in terms of integrating housing and healthcare. Sometimes you can do it within the same building, but we do a lot of scattered site housing using tenant-based Section 8, so using shelter plus care vouchers that are very similar to that. And those folks need ongoing case management and support and access to health and mental health services as well. So one of the ways that we have done that is through a program that we call Housing First. And just wanted to mention the Housing First Collaborative because as we talk about the integration of health and mental health services with housing, it's a very effective way, particularly to meet the needs of disabled individuals and chronically homeless individuals. So it centers around assertive community treatment, or ACT services as it's called, which is, again, an interdisciplinary approach that includes primary care, mental health, substance treatment or addictions counseling, housing assistance, and employment and vocational services. This is a program that has been able to reach or to help folks who have been homeless an average of 8 years before coming into the program to achieve a 92% housing stability and to demonstrate cost savings to the community of over $31,000 by avoiding unnecessary emergency room visits, hospitalizations, detox, intervention with the police or jail, or emergency shelter costs. You can see, and this is from a study we did with the first cohort of folks in the Housing First program, looking at their medical history, medical records 2 years before they entered the program and 2 years after they were in the program. And you can see there was a significant reduction, 32% reduction in terms of emergency room visits, slight increase in outpatient visits, reduction of inpatient visits and hospital nights, and a significant reduction, an 80% reduction in detox, an 64% reduction in terms of incarceration, reduction in emergency room, outpatient costs, inpatient costs, and shelter costs. So overall, again, about a $34,000 savings to the community by providing, and that was after taking into account the cost of that housing. So it's an approach that we were up to 93% housing stability, and the folks that we measure, 50% have improved health status. We're seeing 43% improvement in terms of mental health symptoms, and average increase in income of the participants, as well as we've been able to get folks either into employment or for those who are disabled to get them enrolled in Social Security. So again, the Housing First approach works because it not only saves expensive taxpayer-funded services, but it improves housing stability, and improves health status, it improves the community quality of life as there are less people who are on the streets, and it's a cost-effective way to end homelessness. So when you combine that approach you can do it in a public housing environment. We have been incorporated into the YMCA building, which is just at the end of the 16th Street Mall here. We have 217 apartments within that building now that we own and operate. Half of those units are targeted to folks who are part of our Housing First program, and it provides office space for 3 assertive community treatment teams in the lower level of that building. So again, a great way of integrating health care and housing. So that's the end of the formal presentation, and really just wanted to have an opportunity to answer questions that you might have, and maybe hear from you, how this fits to some of the work, it fits in with some of the work that you're seeing, or some of the needs that you're seeing within your neighborhoods or communities. Any questions? Yes. Mhm. I think that's something that makes a lot of sense, and that we ought to have that conversation. Whether we're the best ones to do it, whether Denver Health is the best to do it. Hurstville is 3 blocks away from Denver Health, right? But that approach, and one of the things that has been a limiting factor in terms of providing services in both medical and counseling services in public housing, whether it's senior housing, whether it's Section 202 or 811 housing. You folks know what that is: housing for elderly, housing for disabled, or even scattered site public housing. Is that the housing authorities haven't been funded to provide those services by and large. In fact, they're not even being funded adequately to provide maintenance and other services. For the most part, the community health system has not been funded to do that, with the rare exception of this primary care and public housing initiative, which is very small compared to the range of housing needs and public housing within the community. So it's something that is demonstrating a success and something that's valuable, but something where there aren't a lot of new grants to be able to do that in a very formal way. But one thing that is changing is the Affordable Care Act. Healthcare reform does provide more incentives in a couple of ways. One is that if that would lead to healthier residents, the folks who are paying for that health care, whether it's Medicare or Medicaid, have an incentive to ensure that people are being improved, healthier lifestyles. And we're looking at more and more initiatives where, because of advocacy and because of targeted approaches, they're looking at ways to improve health outcomes, to improve health status, and to reduce costs. And so if we can make the case, if you and Denver Health, Denver Housing Authority, could make the case that these types of interventions can improve health outcomes and reduce costs, then the likelihood that they will take those cost savings and invest it into these types of services then are increased. There are a number of initiatives that are underway right now trying to demonstrate that and to expand that so it's more readily available. So I'd be glad to initiate or be part of that conversation and see what makes the most sense to provide that. Yes. Right. It is working. We do have one development. Right, if I were to run down all of our developments, 100 comes up a lot. We tend to like that round number. We have 100 units just across from the city and county building. It's a former Denver University Law School that was vacant for 10 years, and the city owned it. And we were able to get them to sell it to us for $1. We renovated it, 100 units of Section 8 SRO mod rehab housing for homeless individuals. That was the first time we did an exclusively homeless development, and it works well. It still is considered, even though the units are much smaller than some that we showed here, because they're single room and they don't have full kitchens. They have little kitchenettes. That environment works well for them. We still expect people, even though we don't screen out folks for drug use and alcohol use, we expect them to follow the behaviors in order to protect the rights of their neighbors. And we expect the same thing when we have mixed unit properties as well. And so a couple of things is that when we expect that of everyone, whether it's a person who's working and maybe drinking after work, or whether it's a homeless individual with a disability and an addiction, our focus is behavioral. It's not on the activity. And as long as they're masked and not causing a problem in terms of the building or causing a disruption to their neighbors, then that works out well. If they do cause a problem, then we'll give them we'll use the case management support to help to intervene. It may give them a second chance. We may give them a third chance. But if they're not going to change the behavior in a way that it's going to allow them to live peacefully and quietly along with others and not disrupt other people's quiet enjoyment, then we may help them move to a different environment that might provide more control. The YMCA building that we've converted, we have a 24-hour front desk that then provides more control within an environment like that. What we find is that, and I'm sure you've seen that, is that when you move someone who's been living on the streets for years into housing, the first thing that they want to do after laying their head on their own bed, well, sometimes they don't even want to lay on the bed. They want to sleep on the floor first because they're not used to a bed. But they want to invite their friend who is still out there on the street in, and that's probably the thing that gets most people into trouble the quickest. And so that front desk provides an ability to help them say no when they're not able to do that themselves. But your initial question was, how does it work with the mixed environment? And one of the most striking things that I've seen in that West End development that I showed, I went to visit it a couple of months ago and got off the elevator, and there's a group of about 5 children, about ages 4 and 5, running up and down the hall. We had a community room on the second level and an outdoor terrace and a community playroom for the kids, but they loved running in the hall. But the mixture of that group of young children and these single adults who had not had connection with family for a long time was actually a stabilizing influence for them. They acted better. I think they liked the fact that they were living in what would be considered a more normal environment than what might otherwise be either a rundown environment of slum housing or a more controlled, sanitized housing that sometimes supportive housing becomes. So I think over the years we have good luck in terms of the integration. It doesn't always work for everyone. I've mentioned in our Housing First example that we have 93% housing retention success rate over 2 years. That doesn't mean it's always in the same unit. Sometimes it'll take moving someone to a second place or a third place before we find the right environment for them. Some folks may initially do better in that controlled environment, or they may react negatively to that and may do better in a scattered site environment. So the choice and the difference and being consumer friendly and providing as much choice as possible tends to increase the outcomes. Was there a question? Yeah. Okay, and one of the things that I think there were 5 homeless individuals that worked on building their own housing here as part of the construction crew. And of course, within the Pizza Fusion environment, we're providing jobs for folks similar to what Denver Housing is doing with the Osage Cafe. I mean, it's a great model. And one of the things that we found is, when people hear that we're going to build supportive housing for the homeless in their community, usually the NIMBY, the Not in My Backyard signs come out. But when we can show them that we're building something that is of quality, that adds to the neighborhood, that we bring in the services to make sure that people aren't left on their own, we're able to get that buy-in from the community. And when this was built, as soon as we started building this, the McDonald's next door decided to rebuild a 30-year-old facility, and so they have a brand new McDonald's there with a McCafe. Across the street, an old Safeway that had closed down and was operating as an Office Depot has rebuilt now, and with another restaurant across the street. And so we're seeing along that rather than this idea that somehow our environment or our buildings are going to detract and deteriorate the neighborhood, they're actually stimulating new development within the community and providing those jobs. Yes. This is at Colfax and Pearl, so just 5 blocks east of Broadway in downtown, just off of downtown Denver. It's if you take the shuttle to the end of the 16th Street Mall, and it's only about 3 blocks to there. It's about another 5 blocks. There's actually, I think, a group is. Other questions? Yes. I couldn't agree with you more on the first thing. And on the second thing, one of the difficulties is that when we build these new buildings and then we have other folks who are working in office space that's less desirable, it's always hard to face up to them and say, this is progress and we're going to get to you. And I think that's the case. The old Stout Street Clinic is the last of those, one of the last of those buildings that has 100 people working in very close environment. And this brand new state-of-the-art clinic is going to provide not only better space for them, but more importantly, better space for the patients, our consumers, and the ability to interact with them better. I didn't mention the electronic health records that we use within our system, but now whether somebody comes to the West End Health Center or sees someone on our mobile health clinic or comes to Quig or goes to the new health center, the provider can pull up their record instantaneously. And if the patient has a question about, what was that test that I had last year, and they can pull it up and print it out for them. So just a greater expansion of care than poor folks have historically gotten. So I think it's a great step forward. It was a good point. You know, I've been working in the healthcare for the homeless arena now for 27 years. Nick works in both healthcare for the homeless as well as public housing clinic. But really the life and blood of the healthcare for the homeless movement has been going to where people are, to helping them where they are, to help them get to where they need to be. And it was an approach that, you know, we started with a part-time doc, a nurse, a social worker, and a front desk person. And over time, you know, have grown into a much larger operation, but have not lost that connection. And I think that to some extent, we think that we really are setting the standard of what everyone should have. I mean, I would love to know that if I have the inability to get out of my home to be able to access my health care provider, that they would come and see me. One of the stories at the West End Health Center is that somebody missed an appointment, and the doc, you know, waited and waited, and they didn't have somebody else waiting for them, so they went upstairs, knocked on the door, and said, "What's up? You know, you're supposed to come and see me." It's not always possible to do that, but in an environment where you have the housing right above, you know, that makes all the difference in the world. And we see about these mental health, unfortunately, has a stigma in our society. But one of the other stories of a patient who has been helped by this approach is somebody with hypertension, high blood pressure. Well, they're given the medication to deal with that, but what we're finding is that if they're depressed, they're not likely to take their high blood pressure medication, and then their condition gets worse. So if you're not dealing with the depression, you're not going to improve the overall health of that individual. And so that joint screening that can identify those other barriers that might then prevent someone from getting the quality health care that they need is going to lead to better health outcomes for them. And again, as I showed, you know, in the housing first model, and it's, you know, it's duplicated by just getting people into housing, is that you're going to reduce costs to the system by providing more coordinated and comprehensive care. That's what this movement's about, and I'm really glad that you all are part of it as consumers and as providers. Yes. You know, what we found is that there's no one solution. You know, collaboration is always great. There are fairly few organizations that have the capacity to do great housing development and healthcare. And you know, we're fortunate that we've been able to do that under one organization. But other examples exist where you have very close alliances between either community housing development organizations that are building the housing and healthcare programs that are providing the health services. We have a progressive housing authority. You know, they can be a critical link within that community. You know, I think in Denver right now we have the highest or the lowest vacancy rate and the highest rents that we've ever had. So despite all of our efforts, despite the efforts of Denver Housing Authority building and renovating more units, we're seeing that the need is far outstripping that. So it's going to take many more actors creating the housing, using every vehicle. Low-income housing tax credits is something that we use a lot to finance the construction of the housing. For this Stout Street Health Center, the first time we used new market tax credits in conjunction with that to get private equity to help with it, as well as a HRSA capital grant, so that made a big difference as well, and a lot of private public fundraising. And we've also seen that there is more interest within the foundation community as well. They see that there is a nexus between housing and health. Unfortunately, Medicaid and the Centers for Medicare and Medicaid, they're afraid of housing. And they're afraid of healthcare funds being drawn into housing, even though it can be demonstrated time after time that better housing leads to better health. But somehow we need to advocate for those partnerships and those collaborations, both at the national level, at the state level, and at the local level to actually implement it. So, I think the place to turn to is some of the communities that have done it well. Look at those models, and look at your community housing development organizations where you don't have an active public housing authority that's willing to do it. Nick? So, so as a CEO, as an executive director, I guess from my vantage point, being able to control those systems makes it a lot easier than having to beg somebody to do the right thing. When you can create an organizational culture that embraces what we've developed, a philosophy of service that both the housing side, the healthcare side, mental health side have embraced, and then you can hold folks accountable to that. That's a lot easier than if you're dealing with somebody who's in a different system. We're dealing with cross systems, like our folks who are working within the Denver Health Clinic at La Casa Quick Newton. There are many things we'd rather them do that we can't control. We don't charge copays for any of our services within our clinic. Denver Health does, and that can provide, that can be a significant barrier to adequate health care for folks who have very little income. So from that standpoint, being able to do it do both sides of it, I think has a lot of benefits. On the other hand, it is challenging because the skills sets that are needed in terms of healthcare financing versus housing financing, HIPAA and healthcare compliance, HRSA compliance as opposed to HUD compliance. They're almost left brain, right brain things, and so if you can assemble a team that can do it, I think it's great. But there are some successful examples where alliances and collaborations have been effective in doing it. So I wouldn't claim that this is the only way to do it, but I think it is an effective way to do it. And sometimes we have tension within our own world, of course, where our housing providers or our housing managers feel that somebody who has just gotten out of prison, who has a long arrest record, who says, I want to make a change. I said, yeah, tell me about it. And you have the advocate, the case manager saying, no, they're really engaged. They're ready for this. Give them a chance. And so that creative tension is there, whether you're dealing it with a third-party housing provider or you're dealing it with a staff person. So you have to navigate those one way or another. But